that subset of sarcomas called leiomyosarcomas, or sarcomas that arise from smooth muscle, different types of tumors behave very differently, in part depending on where the tumor originally arose, whether it was in the uterus, the retroperitoneum, in a blood vessel, or in the skin or bone. And so it's difficult to lump them all together when we talk about the biology of the tumors as well as the treatment options. Up to 85% of all patients with leiomyosarcoma, though, will eventually have spread of the cancer to areas of the body outside of where the tumor first started. And this is called metastasis. When leiomyosarcoma spreads, the most common sites are the lungs, the bones, and the liver. And you might think, well, these are all over the body. What do they have in common? Why are they so hospitable to entertaining metastases from leiomyosarcoma? And one thing that they all have in common is that they all are filters, that they filter the blood. And so if there are any cancer cells in the blood that get filtered out, then they may actually set up shop and basically set up a new colony in their new home outside of where the original tumor was. Metastases are a major source of morbidity, and by morbidity, we mean symptoms and disability, as well as mortality, which we mean death. And as all of you have probably heard, cancer itself, the original cancer, doesn't always represent the most menacing part of the disease. Oftentimes, it's after it has spread is when the real trouble starts. So we can talk a little bit about different spatial targeting of treatments. And the main separation I would offer here is systemic versus loco-regional. So systemic means it goes everywhere in your body. So for instance, if you take a pill and it's absorbed into your gastrointestinal tract and then into the blood, it goes everywhere. So if you take an Advil for a headache, well, that Advil also will treat a sore toe, or any other part of the body that may need Advil, because that goes systemically. I tease my medical oncologist, and I tell them this is like carpet bombing. Like if you have one insurgent that you're trying to hunt down, you don't need to burn down the entire country to get that one surgeon. So the alternative is what we call loco-regional therapy. So controlling the growth of these metastases can prolong survival and improve the quality of life. If metastases are very limited, sometimes they can be surgically removed or resected, which is great because that oftentimes renders the best long-term outcomes. However, many times patients present with metastatic disease that is so extensive or so advanced that you can't cut it out, or the surgeon can't pluck all of them out. And in those cases, it does not always make sense to treat the whole body with systemic treatment. By using loco-regional treatment, basically treating certain parts of the body that harbor these tumors, we can limit the side effects and we can try to kill the tumors where they live. This is more like the smart bombs that the military uses now, that are laser or infrared guided and try to limit the amount of collateral damage done. This is not a new phenomenon. Radiation therapy, which I think most of you have heard of or maybe even undergone, works exactly this way. When the radiation oncologist shines radiation on a patient, she or he doesn't shine it on the entire patient. That radiation is focused on the tumor. What I'm going to talk about, though, are other options in addition to external beam radiation. There are many more options now available, in part made possible by the improvements in imaging technologies, again, in the Department of Diagnostic Radiology, that are allowing these image-guided or imaging-guided, minimally invasive loco-regional therapies. Mostly these are divided into two camps. One is ablation, and the other is catheter-based methods, things that can be injected through a catheter, which is a long, skinny tube. So here are the different imaging modalities that we use to look inside patients' bodies to see where the tumor is and also to see where we are depositing our therapy. So mostly what I use is x-rays, but it's real-time x-rays. So we're not taking a picture and then developing the picture and looking at it 5 minutes later. Using an angiography suite, as you see in the bottom left here, I step on a pedal and I get an instantaneous live x-ray. We can also take movies so that we can see flowing blood or things that are moving. This is what a CT scanner looks like. So it looks like a giant donut and a table that slides into the hole of that donut that gives us a three-dimensional x-ray picture. This looks almost identical to CT. This is an MRI, but instead of using x-rays, this uses a very high magnetic field and radio waves, basically, to look inside us. And this is what an ultrasound machine looks like. What we don't really see here is that they're handheld transducers that are placed on the skin, and these emit high-intensity ultrasound waves that then bounce back so that we can see, essentially, it's almost like sonar, that we can see what's going on inside certain parts of the body. So here we have a picture of a typical tumor. And let's talk about that first set of techniques that we have called ablation. And currently the ones that are available can be roughly divided into 3 different modes of killing. One is heat, one is cold, and one is electrocution. So here we're heating, here we're freezing, and here we're electrocuting. And what this actually looks like, so first, most of the time, and what has been established for the longest period of time, are what we call heat-based ablation options. And the most popular ones now are the top 2, microwave and radiofrequency. Radiofrequency actually has a longer track record. It's been used for over 20, actually close to 30 years. And what we see in the picture on the side here is a needle that looks like sort of like an umbrella, that it has multiple tines that can be spread out in tissue. And this functions as an antenna that we pump in energy, either radio frequency or microwave energy, and it heats up the tissue around it. Most practitioners are now switching to microwave because, as you know, microwave is very good at heating things. That's like the frozen burrito I just had. I didn't thaw it with radio frequency, I thawed it with microwave. So of course, microwave seems to be a more logical option. There are other ways to heat up tissue as well. So there's one that uses a laser, and there's one that uses high intensity focused ultrasound, and we'll go into those a little bit later. In terms of cold, you can also freeze a tumor to death, basically give it frostbite, and that's called cryoablation. And for electrocution, there is something called irreversible electroporation, basically putting enough electricity into a tumor cell that it becomes very leaky and bursts and dies that way. So here's what high intensity focused ultrasound looks like. And there's a diagram of cryoablation where we freeze a tumor into an ice ball, and then electrocution, basically put in electrodes and electrocute a tumor cell. Now, for all of the ablation options, you can see that it's sort of like spot welding. So the smaller the tumor and the fewer the tumors, the better ablation works. So in general, up to about 1 inch or 3 centimeters, and in general, fewer than 5, preferably 1 or 2 targets, are best addressed with ablation. Now, you might ask, well, if there's only 1 tumor and smaller than 3 centimeters, why doesn't a surgeon just take it out? And it's true that many times that is a better option. But unfortunately, many patients are too ill to undergo surgery. And also some tumors are found in places where it's just too dangerous to do surgery, that there may be too much bleeding or there may be too much collateral damage. So here are some pictures of metastatic leiomyosarcoma treated with ablation. So here is a person that has a metastasis in the left lung. This is a CT scan. And in the second picture, you can see that there is a metal needle, which looks white on these images. And the needle has been stuck into the middle of that tumor. And this happens to be a microwave ablation. And in the third picture, you can see that the tumor now looks really blotchy. In fact, we can't really see it as an oval anymore, but it's this whole area of blotchiness, which looks like that because it has not only been cooked, but a rim of normal tissue around it has also been cooked. As many of you know, that tumors, even if they look perfectly round, are not round, that they have these little appendages or fingers that may stick out. And so in order to kill the entire tumor, we also have to kill a halo of normal tissue around it to get all these things that stick out. And so actually in the panel C here, it actually looks worse than it did when we started off because it looks bigger and it looks like there's bleeding or some sort of blotchiness in there. But bleeding, the blood gets reabsorbed and the dead tumor eventually becomes a scar. So we see 1 month, 6 months, and 12 months later that tumor it progressively gets smaller because the body is basically just turning it into a scar. Here's a similar picture using radiofrequency, also in a lung. And you can see again that immediately afterwards, it looks worse. It actually looks bigger. And, but over time, the tumor, because it's dead, gets resorbed by the body and replaced with a smaller scar. However, remember that we want, in general, to treat small tumors and only a few, because every needle we stick into a person, or into a lung, for instance, has some risk. There's risk of bleeding, there's risk of the collapse of the lung, and of course, as I mentioned, we have to ablate some of the normal tissue surrounding the tumor. So if we look at a patient like this, who has dozens of tumors, in order to try to kill all those tumors, we would have to put in dozens of needles. So that's dozens of risks of bleeding and collapse of the lung. And then if you draw a halo around each one of these, that if we were to ablate or to kill normal tissue around each one of these spots, there would be no normal lung left, that these overlapping halos would leave not enough lung for bleeding. So a patient whose scan looks like that is not a suitable target for ablation. If we look at the results for small primary lung tumors, as well as metastases, so primary meaning lung cancer, not leiomyosarcoma that has spread to the lung, but for primary lung cancers, as well as metastases, such as leiomyosarcoma that have spread to the lung, ablation gives equivalent results to surgery. So basically, killing these small spots where they live has the same long-term outcome as a surgeon cutting open the chest and removing the tumor. So here is one curve from a publication looking at ablation of lung mets in patients with either bone or soft tissue sarcoma. So this is not just leiomyosarcoma, but this is all sarcomas. And treated with surgery or with radiofrequency ablation. And you can see that on average, the patients live about 2.5 years, but some patients are lucky and live well over 10 years. And as you might expect, the patients who have more aggressive disease have a worse outcome. And that line A up there represents complete treatment and a tumor volume doubling time of more than 30 days, which means that all of the visible tumor has been killed, and the tumor was a slow-growing tumor to begin with. It makes sense that if a patient has slow-growing tumors and you've killed them all, then that patient is likely to live a long time. But that line D, which is much less optimistic there, of course, is for a patient who has a very rapidly growing aggressive tumor in whom not all of the tumor can be killed. And so, of course, a patient with that situation would not be expected to live as long. Aside from the lungs, the liver is probably the second most common target for ablation. When the liver is overrun with metastases, the patient can go into liver failure. Even before that, the patient can also have pain because the liver has a covering that's sort of like skin. It's called the capsule. And if that skin capsule is stretched by a tumor that's growing, that really hurts. So here is a patient with a metastatic leiomyosarcoma, but only one spot in the liver. And here's that fancy needle that looks like a miniature umbrella that under CT scan guidance has been put into the liver, and the umbrella is opened. And then that area, again, the tumor as well as a rim of tissue, of normal liver tissue around it, has been literally cooked. That's a meatball inside this person's liver, but it's a dead meatball. And that's what we want. We want that tumor to be dead. Again, just similar to the pictures that I showed earlier, a patient that has multiple tumors like this is not a good target for ablation because there are too many spots, and killing them all would not leave any normal liver left. Likewise, the biggest meatball we can cook is about 2 inches in diameter. So a tumor like this, which is more like 6 centimeters or 6 inches in diameter, there's no way that we can cook this whole thing using ablation. So this would also not be an appropriate patient for ablation. And the third filter that we talked about is the bones. Sarcomas can actually arise in bones as well, but because bones also filter blood, they can also be sites of spread or metastasis of other cancers, including leiomyosarcoma. So here's a patient with a metastasis in the pelvis, causing some pain. Even if these things are not immediately painful, metastases weaken bone. So depending on what bone is involved, there can be fractures of the bone. Also, if it involves the spine and if it enlarges a certain spine or vertebral bone, it can actually press on nerves, such as the spinal cord. So here is one patient who has pain in her pelvis, and by drilling a hole into the bone and introducing one of these ablation needles, we're able to cook the tumor cells that are causing this metastasis. Here's a patient with a much larger tumor. We have no realistic opportunity to kill all of the tumor involving this person's sacrum. However, this person is in excruciating pain. So what we can do with ablation, at least, is kill the parts of the tumor that are most likely to be causing pain. Here's a person who has a metastasis in a spine bone, a vertebral bone. You can see that it looks like a dark space that has replaced the bone there. And when these get large enough, these weaken the bone. And so a patient with a metastasis like this is at risk of that bone collapsing. So in this case, an interventional radiologist has drilled a hole into that bone, placed the ablation needle into the tumor, and cooked the tumor. Now, even with the tumor dead, at least it won't get any worse, but there's still missing bone there. So that part of the bone is still weak. And in fact, any normal bone cells there that would be involved with replenishing that hole with new bone were also cooked. And so what this technology allows, though, there's already a tunnel drilled into that hole. So that hole has been filled with cement. And that's what that bright white blob there is. So it's a very hard cement. It's a synthetic plastic, basically, that's injected in there and solidifies and strengthens the bone. Working alongside with orthopedic surgeons, even more aggressive bone therapies can be done. Here's someone whose hip is falling apart. And so the first thing that is done is that the ablation needle is inserted into this area to ablate with heat as much of the tumor cells as possible. And then you can also see that in addition to, now this stuff now looks dark because this is a regular X-ray instead of a CT scan, so it's sort of a negative. But the cement that has been injected is those dark colored blobs in picture D and E. In picture F, it's flipped again, so now bone is white and the cement is also white. But in addition, there's actually a screw. So that screw actually is going through the bone to connect the two halves of the bone that were basically separated from each other because they were eaten away by the metastasis. So these are all mechanical methods for strengthening the bone to prevent bad fractures. One of the new heat-based ablation technologies that has everyone very much interested is something called HIFU, or high intensity focused ultrasound. And so these can be used anywhere that the sound waves can reach. And right now they're mostly, this technology is mostly used to address pain. Oftentimes we use this if a patient has already undergone external beam radiation therapy, but where that radiation therapy has not resulted in the relief of pain. So in this case, a patient is actually put in an MRI imaging scanner, but the patient lies on a specific type of bed that is full of water. And on the other side of that water mattress is a very high intensity transducer of ultrasound. And by using sort of like a lens to focus that ultrasound, so the ultrasound is like vibration. And if the vibration can be intense enough, it can also create heat. And so what we see on the picture here is that if it's focused on one spot, and that spot being a tumor, we can actually heat that without even sticking a needle into it. And this is what a live MRI looks like. This is the person who's lying on his side, and the femur or the thigh bone is being targeted with this high intensity focused ultrasound. All right, so that was the half of the image guided therapies we call ablation. I'm now going to move on to the other half, which is the catheter-based therapies. And remember, a catheter is a long skinny tube about as thick as maybe a coat hanger. And most of these catheters are used to get into blood vessels. And for this purpose, we don't usually go into veins, we go into arteries. So the difference, of course, veins are those blue blood vessels that you see like maybe on the back of your hand or something, where when you go into the hospital, a nurse tries to put an IV into the vein so that medications or fluid can be injected. The veins carry blood back to the heart, and the heart, of course, distributes blood throughout the rest of the body. The way the heart distributes the blood to the rest of the body is through a system of arteries. So the arteries are much, much higher pressure. In fact, when you feel your own pulse, like on your neck or on your wrist, that pulsation is in the artery. And that blood carries a lot of oxygen, a lot of nutrients, as well as high pressure. So in those pictures where you saw patients had too many tumors in their liver or in their lungs, they are not good candidates for ablation. Sometimes even if a patient only has one tumor, but it's right next to, let's say, the heart, and we don't want to cook the heart, so then ablation also is not a good option. So what we try to do then is we try to poison the fuel line, because tumors, in order to grow extra fast and out of control, tumors need a lot of oxygen. Tumors need a lot of nutrients, because they're sort of like teenagers that are, eating you out of house and home and clearing the refrigerator every day because they're growing so fast. Now, some organs also have the advantage that they have dual blood supply, meaning there's two different types of arterial blood going into that organ. And the liver and the lungs both have this. So in that case, one of the blood supplies is favored by the normal healthy parts of the organ. And the other is favored by the abnormal extra thirsty tumors. So in order to find Waldo in the midst of that crowd, what we want to do is find Waldo and not find anyone else. So if we have a liver here depicted as this sort of triangular red organ, that is full of tumors, which is depicted as these green dots. It's really easy to kill all of those tumors, but with collateral damage or damage to the liver. However, you can't live without your liver. So the challenge is, how can we kill the tumors without killing the liver? And that's the big question. And again, the dual blood supply of the liver is something we can take advantage of. And here's an old classic anatomy picture from 100 years ago. And in this picture, the dark red branching structures is the hepatic artery. So that's the blood that comes from the heart. It's at high pressure. It has a lot of oxygen in it, and it has a lot of very processed nutrients in it. And in dark blue is something called the portal vein. And the portal vein also introduces blood into the liver. But tumors don't like portal blood, because portal vein blood comes from the intestines and the stomach. So it carries nutrients, but it carries nutrients that were just absorbed and have not been biochemically broken down in a way that the tumors can use them. So one of the main functions of the liver is actually to help digestion, that it takes these newly absorbed nutrients from the stomach and the intestines, and it chemically breaks them down into things like sugars and amino acids that the rest of the body can use. So the liver normally receives about 70% of its blood from the portal vein and only about 30% from the hepatic artery. But again, tumors don't like portal vein blood, so they receive over 90% of their blood exclusively from the hepatic artery. So as you know, I work at Stanford, and even though this was before my time, I like using this analogy because I have friends at Stanford that are still very bitter about this. So you guys might recognize this is the game back in 1982, the big football game between Cal Berkeley and Stanford. And what happened at the very last play of this game, Stanford had thought it had already won, but Cal did this fancy schmancy play where they lateraled the ball something like 10 times, and the player ran into the end zone, and while Stanford was already celebrating, the game wasn't over yet, and so Cal actually scored a touchdown and won. So my friends at Stanford are still really angry about this, and so this is what they would propose as a way to get back at Cal, but this is what I would propose as a way to get at the tumors. So once everyone is in the stadium, they're all mixed together. So you can't pick out Cal fans and Stanford fans that easily. But as they're going in, at the Stanford entrance, you can set up a food truck with lots of yummy food. And at the Cal entrance, you set up another truck, but you serve them spoiled food. And that way, even if the fans intermingle in the stadium, only the Cal fans get the bad food and the Stanford fans get the good food. So as an analogy, in the liver, I don't want to harm the liver. I only want to harm the tumors. And so by putting harmful materials into the artery, by infusing chemotherapy, by infusing basically medical grade sand that goes down and plugs up the flow of blood, or a combination of these, that's called Chemo Embolization. I can also use medical grade sand that's radioactive. So in addition to plugging up the blood vessel, it also emits radiation. So whatever we use, that will selectively target the tumors. So the techniques that we use are becoming more and more specific for tumors as well. In another analogy, if your lawn has a lot of weeds in it, one way that you can get rid of weeds is you can spread weed killer over the entire lawn. A potentially better technique, if those weeds are only in one part of your lawn, you don't have to spread the weed killer everywhere, but you can actually spray it right where the weeds live. So the chemo embolization works this way, that we can inject very concentrated chemotherapy that's mixed with a sticky oil, or there's a newer technique where we take what are called drug-eluting microspheres, which are like tiny sponge balls that are each about as thick as a human hair, and we can soak them with very concentrated chemotherapy. And by injecting them into the tiny blood vessels that are feeding blood to the tumors, we can then give an extremely high concentration of chemotherapy to the tumors, and we can plug up the blood to prevent those nutrients and oxygen from reaching the tumor. So we get a very high local dose of chemotherapy. The chemotherapy sits there for a long time because there's no blood to wash it out. There's also ischemia, which means lack of blood and oxygen and nutrients of the tumor. And because we trap the chemo right in the tumor, there's very limited toxicity to the liver and systemically. So in general, the liver function is maintained, and those normal side effects that we associate with chemotherapy, like nausea and vomiting and fatigue and hair loss and diarrhea, in general, either don't happen or don't happen as severely. So here's one example of a leiomyosarcoma treated with chemo embolization. This is an MRI before treatment, and the arrow there points to the largest tumor, which is right next to the inferior vena cava and the kidney lying behind it. We treated that. This is what the angiogram looks like, and the largest black blob here is that tumor, and you can see that there's some smaller blobs elsewhere that we also treated by navigating a catheter into the individual branches of blood vessels that feed these tumors. And then this is what the MRI looked 3 months after treatment. So that whiteness of the tumor is now replaced with blackness. So on these MRIs, white means very thirsty for blood, and in this case, meaning an aggressive tumor. And blackness means no blood vessels. And so we were able, at this point, at least to kill most of that tumor and to shrink it. A very similar technology that we use more frequently than chemo embolization now for leiomyosarcoma is something called radio embolization. Some people call it RE, some people call it TARE, and some people call it Y90. And the reason why we call it Y90 is that the radioactive material that we use is called yttrium-90, and yttrium starts with a Y, so it's called Y90. The physicists would say it's a pure beta emitter, which means when it gives off radiation, it gives off only beta particles, which are electrons. And these electrons are relatively heavy, which means that they can't go through much tissue. On average, only 2.5 millimeters, which is about 1/10 of an inch, and maximally about 11 millimeters, which is less than 1/2 inch. So this is very different from the kind of radiation that is administered externally, like when you go to a radiation oncologist and they have a big machine that shines radiation from the outside. It goes through inches and inches of regular tissue before it gets to the tumor. But this is a type of very, very localized radiation that is emitted from inside the tumor after we inject it into the tumor. This is where yttrium lives on the periodic table. The half-life of yttrium is 64 hours, which is about 2.5 days, which means that it emits radiation for a few weeks before it goes cold. So the rationale of using radio embolization, again, is pretty similar to what we've been talking about, except that the liver is very sensitive to radiation. And if the liver gets over about 30 grays of radiation, it starts to die. It goes into what we call veno-occlusive disease or radiation-induced liver disease. And when the liver gets sick, no one's happy, especially the patient. Tumors, unfortunately, may be resistant to radiation, and some of them can tolerate up to 60 or 80 grays. Above about 80 or 100 grays, pretty much everything is affected. But this presents a challenge. So how can we give more radiation to the tumors than the liver, knowing that the tumors are in fact less sensitive to radiation than the liver is? And again, we can take advantage of the dual blood supply, that the tumors are extra thirsty and they don't like portal vein blood. They only like hepatic arterial blood that has all that oxygen and the processed nutrients in it. So if we inject radioactive microspheres, which look like dust, into the artery, whatever parts that are the most thirsty get the most radiation. There are two formulations commercially available. One is called Cerspheres from Australia, and one is called TheraSphere from Canada. The Cerspheres are FDA approved for treatment of colorectal cancer that has spread to the liver, and TheraSphere is approved for primary hepatocellular carcinoma, or liver cancer that started in the liver. You'll notice neither one of these are approved for treatment of sarcoma, which means that if we want to use these, we have to use it in a way that's called off-label, meaning not approved by the FDA. So that means that your insurance company might look at this and say, hey, that's not an approved use of this stuff, we're not going to pay for it, which means that we have to go through a lengthy appeal process to convince them that this is the right thing to do. Now, at what point are one or both of these going to be FDA approved for leiomyosarcoma that is spread to the liver? Well, in a word, never. Because in order to do a trial like that, we would probably have to treat 500 to 1,000 patients. We would have to flip coins so that half of them get the treatment and the other half don't get the treatment. And there just aren't that enough patients with leiomyosarcoma that has spread to the liver in order for us to do a trial like this. The trial would probably also cost tens, if not hundreds of millions of dollars. So these companies are not interested in doing that, unfortunately. So here's the first patient I ever treated with leiomyosarcoma with radioembolization. This is what the CT scan looked like before. And the liver is on your left here. And these round white dots in it each represent a tumor. And again, there are too many of them to do something like ablation. This patient has already undergone multiple different types of chemotherapy, and these tumors continue to grow. So after treatment, this is what it looked like 3 months later. You can see that all of the tumors are smaller, and instead of being white, now the centers of them are black, meaning that they are no longer thirsty for blood. Some of them actually have a rim of whiteness. We call this rim enhancement. It isn't always clear what rim enhancement means, but sometimes this can represent a good thing. It can represent inflammation, meaning that the immune system of the body has recognized that there is something wrong here, that there's tumor, live or dead, and is surrounding the tumor and eating away at it. And this is that same patient 19 months later at the same level. You can see that by now, pretty much all of the tumors are gone. Unfortunately, this patient a few years later did develop more tumors in the liver, and so we treated her a second time. So a bunch of buddies of mine got together. Some of the buddies were from University of Indiana in Indianapolis. Some were from University of Washington in Seattle, and some were at Northwestern University in Chicago. And we combined our patients who we've treated with metastatic sarcoma. You can see that 15 of the patients came from Stanford. We've since treated probably about another 10 or 15 patients. And all of us had noticed independently that sarcoma usually is considered to be a tumor that's not very sensitive to radiation, not very sensitive to chemo, and it's just really difficult to treat. And when patients with sarcoma that has metastasized to the liver, the clock is ticking. And we usually expect these patients to live less than a year. But after treatment with radioembolization, you can see at 1 year here, about 2/3 of the patients were still alive. And some of these patients, including that patient that I showed on the last slide, even 6 years later are still alive. Now that doesn't necessarily mean they're cured of their leiomyosarcoma, but it means that at least they have not died from it. So this is one of the targets that the people in my field are actually focusing in on because of this unexpectedly favorable result of outcomes of treatment of metastases to the liver using radioembolization. So there are other targets for chemoembolization and radioembolization. The lungs, for instance, do have this dual blood supply of pulmonary artery and bronchial artery. However, treatment of the lungs is higher risk. Even though the bronchial arteries preferentially feed the tumors, bronchial arteries frequently give off branches that go to the esophagus and to the spinal cord. So if we spill any chemo or radiation into the esophagus, you could get an ulcer in the esophagus, and that's a really nasty thing. You can imagine if you swallow some food, and instead of going to the stomach, but it goes out a hole in your esophagus into your chest, that's a life-threatening thing. And likewise, if there's damage to the spinal cord, as you all know, the spinal cord is sort of the electrical system of the body. If the spinal cord is injured, then a person can become paraplegic. So currently, the use of chemo embolization and radial embolization in the lungs is limited to very, very small clinical trials. In terms of the bones, the problem is that the bones only have a single blood supply. There's not a dual blood supply. So occasionally, we will do chemo embolization or embolization without the chemo, mostly to address pain. But because there's only one blood supply, at the same time that we kill the tumor, we kill whatever living bone is there as well. So the liver remains the most suitable target for these technologies. Anecdotally, I've also treated some other parts of the body when there's limited disease that can't be treated other ways, including the spleen, the lymph nodes, parts of the pelvis, including the uterus, the pancreas, kidneys, and breasts. So in conclusion, although many leiomyosarcoma patients have spread of cancer systemically, including into the lungs, liver, and bone, but there are technologies that have been developed in the past few years that can address these without the use of systemic therapy, because our spatially targeted methods can attack these metastases using ablation or embolization technologies, even though they're not usually considered curative, but they can result in substantial benefit, including relief of symptoms and extension of the length of life. Many of these treatments, though, are off-label because there aren't good enough published data on the treatment of leiomyosarcoma, which means, again, sometimes when we propose doing this, your insurance company will say, we're not going to pay for that because that sounds like an experiment. But we are gradually accumulating enough data that we can convince the insurance companies that this has a good enough chance of working that they should pay for it. And lastly, I want to just remind everyone and encourage everyone, cancer, including leiomyosarcoma, including metastasis from leiomyosarcoma, is not an automatic and immediate death sentence, even after it's spread, because most cancers now can be treated as a chronic disease, sort of like high blood pressure or diabetes. Now, diabetes will kill you, high blood pressure will kill you, but we don't send patients with diabetes home to die. And we don't send patients with metastatic leiomyosarcoma home to die either, because people aren't just dying of the cancer, people now are living with the cancer. All right, thank you.
Thank you so much, Dr. Z. I mean, isn't he understandable? I can kind of get it from all of this. It's a lot of information, but it's so nice to be able to have information that a patient can understand so they can talk to their doctor about it. We have some questions in the chat. Let me see if I can find those.
Yes, I can see that.
Can you see them?
Yeah, I can.
Answer those? Okay.
Yeah, so why don't I go through top to bottom. So the first one from Jennifer Russell is the cement injected during the same procedure as the ablation. So yes, if we are ablating a tumor that is affecting a bone, the cement is injected at the same time, at the same procedure, and through the same hole, because we don't want the bone to remain weak for any additional amount of time.
That makes sense.
Okay, and the second question from Sharon Anderson, what is the growback rate after ablations? So for the perfect target of ablation, and again, that perfect target would be a single spot that is less than 3 centimeters in diameter. For most organs, the growback rate is very low. It may be less than 10% at 1 year. In some cases, in some hands, it may be even less than 5% at 1 year. Now, the issue for all of these technologies, though, is that if a tumor has already spread from one place to another, in general, the way that tumors spread is that they seed the bloodstream, that they're individual tumors that get into the blood. And that's also why the liver, the lungs, and the bone are frequently affected again, because they are filters of blood. But in general, if I see one spot in the lung, then I kind of know. It's like seeing one dandelion on your lawn. Is it really true that your lawn only has one dandelion? So if I pluck that dandelion, the likelihood of that dandelion growing back is very, very low, right? Because I've thrown it away, it's in the compost bin. It's not going to grow back. But what's the chance that a different dandelion is going to grow? And that chance is much, much higher. And some cynics would say it's nearly 100%, because it's almost impossible that one dandelion seed landed on your lawn. Chances are multiple ones landed. It's just that we haven't seen where the other ones are going to spring up yet. So that's one of the disadvantages of ablation, is that even though you can kill that one spot, it's not necessarily a cure, because there may be microscopic disease that is too small to detect by CT scan or MRI, but in the months or years in the future, that spot may arise. Okay, next question from Alicia Schaefer. What techniques can be done while on chemotherapy? So that's an excellent question. Even though we try to limit the amount of side effects by doing these loco-regional therapies, as you all know very well, every therapy has side effects. You can't believe all the marketing. Like, even when I tell you, oh yeah, the chance of you throwing up is almost zero, you know there's a chance you're gonna throw up, right? I'm sorry, but that's the marketing. So in general, we have to look at a person's performance status, or basically how robust that person is. Some of our patients are 25 years old and they look like, you know, they just walked out of the gym, and you give them chemotherapy and they get a little tired for a day, but they bounce right back. So those patients, we would be much more willing to be aggressive on, which means that if they're on chemo, we might not stop the chemo if that person needs a local regional therapy like an ablation. But now if we have someone who is 85 years old, who spends all day in bed and who is on chemo, I'm pretty sure that if I did an ablation on that patient would not recover that easily. And so we do try to tailor our decisions based on what we think a patient can tolerate, because we certainly don't want to decrease a person's quality of life so much at the expense of killing a tumor. Okay, next question from Sharon again. How do you pick which technique to use on which tumors? So again, the size of tumors matters, the number of tumors matters, and the location of tumors matters. So for ablation, again, single tumors or up to 2 or 3 at one session. And in general, RF ablation, or radiofrequency ablation, can kill something up to about 3 centimeters in diameter. Microwave a little bit bigger, about 5 centimeters. But if something's greater than 5 centimeters, ablation is probably not a good option. Even if a tumor is small, let's say if it's 3 centimeters, but it's touching the heart, well, I don't want to cook that halo of normal tissue around the tumor if that halo includes the heart, right? No one wants a hole in the heart. Or there are other critical structures also that we cannot afford to harm. And so in cases where ablation doesn't work, then we can think of, well, okay, will an intra-arterial catheter-based technique work? Or will external beam radiotherapy work? Or we have other options then to consider. Okay, next question, Gail Kaufman. Which types of imaging are recommended for which purposes, and which are most accurate, and are PET scans at all reliable? That's a very good question. So it's often difficult. In fact, I don't know how many of you read your own radiology reports, but it can be really frustrating when a radiologist is not certain and has to hedge her or his bets on the diagnosis. And that's something we always make fun of radiologists. When the report says, well, this is either just a trivial normal variant, or it's a life-threatening condition, I'm not sure which. It's like, how does that help us? Like, we really want to know, is this life-threatening or not? And so that's why oftentimes after one set of imaging, there may be a recommendation to get a second or even a third set of imaging just to be more sure. So all these images look at different things. So X-ray based images just look at how well a tissue can stop an X-ray. If we inject contrast, the contrast contains iodine, and iodine stops X-rays or blocks X-rays. And so if a tumor is extra thirsty and we color the blood with iodine, then anything that's extra thirsty can block X-rays really well. And so those will show up as white on the CT scan. And an MRI, even without contrast, can show more resolution of tissue, of whether, for instance, by X-ray, different tissues look the same. And what I was taught is meat looks like meat. So whether it's liver meat or muscle meat or stomach meat or spleen meat, it all looks the same. But on an MRI, it looks different. The liver looks very different from the muscle, which then looks very different from the spleen. And so an MRI can help to distinguish tissues better. MRI also can use contrast, but instead of using iodine contrast, we use gadolinium. So gadolinium is sort of like, it's almost like microscopic magnets that are injected so that, again, remember that MRI uses a magnetic field to generate its pictures. And so, again, if we inject tiny magnetic material, then whatever's most thirsty for blood takes up the most of that magnetic material. And so that also shows up as what we call contrast in MRI. A PET scan works completely differently, though. A PET scan, we take sugar, just glucose. So it's the type of sugar that every cell in your body uses as an energy source. But we make that sugar radioactive. And we make it radioactive in a way that if the tissue that is using that sugar as an energy source, it takes in that radioactive sugar, it prevents that radioactive sugar from leaving that tissue. So it accumulates in that tissue. And so any tissue that uses a lot of sugar, that includes the brain, the normal parts of the brain, that is. The normal parts of the brain uses a lot of sugar. And so when we inject this radioactive sugar, it gets taken up by the brain and it stays there. Then what we do is we use a PET scanner to detect where did all that radioactivity concentrate? Where did it accumulate? And of course, we want to see, yeah, it accumulated in the brain. At least there's some people in our government that we might suspect it would not accumulate in the brain. But I assure you, even in our government members, it accumulates in the brain. However, we know how much it should accumulate in the liver. And there's something called the SUV. So the SUV of the liver is usually about 2 to 3. So if there is a spot in the liver where the SUV is higher, let's say it's 10, that means there's a spot in the liver that is using and accumulating more sugar than normal liver. And then we know that metabolically, there is a tissue in there that is revved up and growing fast. And in general, that's going to represent something like a tumor. Now, something like infection is also revved up and can also be hot on a PET scan. So even a PET scan is not 100% specific about whether something is a tumor or not. Okay, from Rhonda Meredith, for liver taste, what is the risk of unintentional effects to adjacent liver tissue? That's a great question. So for both chemo embolization and radio embolization, there is collateral damage to the liver. We try to minimize that collateral damage, but there always is collateral damage, in part because in a similar fashion with ablation, we can't just kill the tumor. We also want to kill a little halo of normal tissue around the tumor, because the tumors stick out these little appendages. Because tumors want to spread, right? So we got to kill those little appendages that represent the early spread. Fortunately, we are each given a lot more liver than we need. So if you remember the old Greek mythology about Prometheus, so Prometheus was a guy that gave fire to humans. And Zeus was so upset with him that he tied Prometheus to a rock. And every day, a giant bird, depending on how you translate it, it's either an eagle or a vulture or a crow, would pick at Prometheus's body and eat his liver, but not the whole liver. It would eat half the liver, and then it would be satisfied and go away. And the next day, Prometheus's liver would grow back because it would regenerate. But then that night, the vulture would come back and eat the half that grew back. So it's an interesting story in that even 2,000 years ago, people, I mean, this is before there was such a thing as surgery, but even back then, people knew the liver can regenerate, it can grow back. And they also knew that if you're missing half the liver, you don't die. So we are, again, given about triple the amount of liver that we need, which means that if a patient has metastases in the liver that occupy half or 2/3 of the liver, there may be the option of cutting out 2/3 of the liver by a surgeon and just getting those completely rid of those tumors. Because even having 1/3 of the liver left behind is enough to sustain adequate liver function for a person to live normally. So when we do chemo embolization and radioembolization, we have that similar fallback that we could theoretically kill up to about 2/3 of the liver and still get away with it. So we don't want to kill that much liver. We try to minimize the amount of liver we kill. But yes, there always is going to be collateral damage to the liver. And that can manifest itself sometimes in liver function tests, particularly if done a few days after treatment when the liver is the most affected. Okay, the next question from Jennifer Russell. Could you talk a bit about radiation to gynecological organs and risk of damage to local tissues? Yeah, so radiation, the cynical thing we say in medicine is radiation is the gift that keeps on giving. That you would think that as soon as they turn off the radiation beam, that the effects are over, but that's not, unfortunately, that's not true. Radiation causes a lot of scarring, which we call fibrosis. So even though in many cases radiation is the best way to kill a tumor, there's always going to be collateral damage around where that tumor lived, and that collateral damage could be very long-term. It could be for the rest of your life. So for instance, for a gynecologic malignancy, yes, the gynecological organs live in the pelvis, but they're not the only things that live there. The bladder lives there, the rectum lives there, parts of the large intestine live there, there are blood vessels that live there, there are lymph nodes that live there. And if any or all of these are also included in the radiation therapy, these will have adverse effects on these organs. So for instance, if there's too much radiation to the bladder, you can get something called a radiation cystitis, meaning the bladder gets really angry and inflamed from the radiation. It gets very thick-walled, so it doesn't expand very well. The muscle in the bladder doesn't work very well, and the inner lining of the bladder can actually turn into something that looks like hamburger, and it can bleed a lot. And in the worst case, it could be so bad that the bladder has to be removed because it can't stop bleeding. So that's just one example of collateral damage that can happen in the pelvis from radiation treatment. There are a number of other things, including bowel obstruction. If there's scarring to the bowel, there can be lymphedema if there's blockage of the lymph nodes. So unfortunately, there are a lot of things that can happen. Nevertheless, that doesn't mean radiation's always bad or always the less recommended option. Sometimes even with all these risks, sometimes radiation is the best option. Okay, next from Jeff Wade, is there any interventional radiation approaches to assist with scar tissue causing pain 3 years after treatment on S1 nerve root from your prior SBRT? Okay, so SBRT, for those of you who are not familiar with it, is stereotactic body radiotherapy. So it's a very, very focused way of using external beam radiation. So S1 nerve root is, so it's in the back of the sacrum, and it's one of the branches that comes out of the spinal cord, and it comes out through a hole of the sacrum there. And so in Jeff's case, what he's asking is that there was probably radiation damage to that area, so there is scarring. As all of you probably know, a scar first starts off as being pretty big. Like if you fall and scrape your knee, you start off with a big scar, but over years that scar gets smaller and smaller, right? Or if you have a cut that is long and fat, like from surgery, for instance, over the years, it becomes skinnier and it even becomes shorter. So it contracts, right? Scars contract, that's just what they do. That's part of the fibrosis process. So if you can imagine that if there's a scar in a confined area around a nerve, as that scar continues to contract, it'll squeeze the nerve. And that can be very painful. That can also cause weakness because the nerves not only carry sensation, but they also carry the electrical signals telling your muscles to move. The short answer to this, Jeff, unfortunately, is that there are not great options for relieving pain caused by radiation-induced scarring. There are ways to kill that nerve, to stop the pain, but the collateral damage of killing the nerve is that whatever muscle that nerve was connected to is going to be weak. And also whatever parts of the body that were feeling normal sensation, like cold and heat or light touch, will become numb if we kill that nerve. So it is possible that if the nerve pain is so bad that there are ways to kill the nerve, but there can be a big price to pay for killing that nerve. There are also other medications that can be taken, like gabapentin or Lyrica, that can sometimes help with neurogenic pain. Okay, next, from Arthur Barbosa. Is it possible or recommended to use any interventional radiology technique, ablation, SBRT, et cetera, to metastases located on skeletal muscles? Yeah, so that's an interesting question. So the muscle is not a very common place for metastasis, but sarcoma is one of the cancers that can spread to skeletal muscle. And in those cases, if it's small, if it's less than 3 centimeters, and if the numbers of spots are few, then yes, ablation can be used. Now again, if there is a halo of normal muscle around it that's killed, that will constitute the collateral damage. And so there may be some weakness involved. SBRT, which is the external beam focused radiation, can also be used. The catheter-based ablation, I've used it a few times in a few patients who had no other options. It can be a challenge because the same blood vessels that go to muscle can also go to nerves and can also go to skin. And you can imagine that if we spill some of the chemotherapy into skin, you can get an open sore, which is nasty. Also, if we spill the chemotherapy into nerves, that can also chemically irritate the nerves, which can also cause pain that is hard to make it go away. So of those options, probably SBRT, sometimes surgical resection, or ablation are usually your options. Okay, from Hannah Wynn. I have 5 nodules in my lungs, metastasis from uterus, Leiomyosarcoma. The biggest one is 1.8 centimeters. Can surgery resect 5 nodules in lungs, or what is the best treatment for it? My oncology plans chemotherapy, gemcitabine, and docetaxel. Thank you. Okay, Hannah, so oftentimes, as we said, surgical resection can give the best long-term outcomes because the tumor is physically removed from your body. So a lot of these other options may kill 99% of the tumor so that on a CT scan or MRI it looks dead, but that 1% can grow back. Now for surgery, if they completely remove it from your body, it's not going to grow back. There may be new spots in other parts of the lung that can grow back. And so that's why not everyone gets surgery. So as part of the recovery process of surgery, your body has to produce new scarring, right? And in order to produce new scarring, your body produces growth factors that helps to heal and helps to produce scars. Those growth factors also make tumors grow faster. So the problem with some surgeries is that if they can't get everything out, then what they leave behind accelerates in growth. So in general, a surgeon will not agree to do surgery on the lungs or elsewhere unless the surgeon thinks there's a good chance that she or he can get all the cancer out, right? So 5 nodules in the lungs, a good thoracic surgeon can get 5 nodules out while leaving enough normal lung behind so that you're not continuously out of breath. The problem is if you have 5 that are big enough to see on a scan, you could have another 5 that are still too small, or you could have another 500 that are too small to see. So a lot of times a surgeon will have a patient go on chemotherapy and do what's called the test of time. And what that means is similar to the dandelions on your lawn. So after I pick that dandelion up, what I might do is just say, okay, I'm not going to mow the lawn. I'm not going to put on. I'm not going to try to get any, try to pick any more dandelions. I'm going to wait a month or 2 and see, are there any new dandelions that pop up? So that's what the surgeon may do as well, is to put you on the chemotherapy, wait for a number of months to say, are there any additional spots that are going to pop up in the lungs? Because if there are additional spots that pop up, that means that removing those 5 spots is not going to benefit you, right? Because even though those 5 spots are gone, there are other spots that are going to pop up, and the removal of the first 5 is going to accelerate the growth of what is left behind, okay? Now, if, let's say, 3 or 4 or 6 or however many months down the line, you've been on your gem docetaxel, and you still only have those 5 spots, and nothing else pops up, then go back to your surgeon and say, hey, it's time to reconsider surgery because it looks like my lawn does not have other dandelion seeds in it. Okay. From Sue, can these techniques be used in an area like the retroperitoneum rather than an organ? The short answer is sometimes. So the retroperitoneum in general only has one source of blood also. So unlike the lungs and the liver, it does not have this dual supply. There have been a few cases where I've been able to do chemo embolization. There's been one case where I did a radial embolization in the retroperitoneum. But again, these tumors have to be situated in a way that if I kill some normal tissue around it so that there's some collateral damage, that it's not catastrophic. And the retroperitoneum does have a lot of things that we really don't want to mess with too badly. So things like the kidneys, the adrenal glands, the ureters, their blood vessels back there, their lymph nodes also. So there are definitely things that we cannot afford to harm. Once in a while, though, there are tumors in the retroperitoneum, for instance, that they may be surrounded by muscle or something, where a little bit of damage is tolerable. And so these technologies may be applicable. Okay, from Ellen de Jong Ozeri. Tara, how many can you go for at one time in the liver? How many tumors? The pain when liver tumors are growing, can you repeat that? So just the same thing that when you're spraying weed killer on your lawn, you have the option of spraying it on your entire lawn or only on part of the lawn. So for chemo embolization and radial embolization, we have those same options. That if you have only one part of the liver that is involved with tumor, we have the option of only treating that part of the liver and leaving the rest of the liver alone. As you can imagine, that's probably safer to do that because there's really no point in spraying weed killer on a part of your lawn that does not have weeds. So the part that we spray, it doesn't matter that much how many tumors there are or even how big the tumors are. Now, it's true that the bigger the tumor, the harder it is to kill. And the more tumors they are, the harder it is to get all of them. But if there's one part of the liver that I can be aggressive on, whether it's 5 tumors or 500 tumors, they're all going to be affected. And then the pain when liver tumors are growing. So the inside of the liver does not have much in terms of sensation. So it doesn't have nerve endings. But the outside of the liver, there is that cover that is sort of like a skin, and it's called the capsule of the liver. So most of your internal organs have a capsule. So for instance, the spleen has a capsule, the kidneys have a capsule. Well, the liver has a capsule too, and the capsule has nerve in it. And so if the capsule gets scraped, it hurts. If the capsule gets stretched, it hurts. So for instance, if any of you have ever had a liver biopsy where someone has had to stick a needle through the skin, through the capsule of the liver to get a piece of tissue so that the pathologist can look at it under the microscope, when the needle goes through the capsule of the liver, there's a sharp pain because it has nerves. So likewise, if there's a tumor that lives on the periphery of the liver and that tumor is getting bigger, so it's stretching the capsule, that can hurt too. And so sometimes these treatments that we're talking about, even if they're not curative, even if we can't kill all of the tumor, if we can kill it enough that it gets smaller, it gets partially dead so that it gets softer, that can relieve the pain. So even though we may not extend the life expectancy of a patient, if we can make that life pain-free, I think that's still worth doing. Okay, from Jennifer Russell, could you talk a bit more about cryoablation? Yeah, certainly. So cryoablation is the technology where instead of cooking a meatball, we freeze the meatball. And it's just like, I don't know if any of you are not California natives, but I'm from the East Coast. And when I was a kid, I think I was about 7 years old, I was out with my buddies after snowfall, and we had a snowball fight that went on for about 4 hours. And my pants got wet and my shoes got wet, and then they froze. And so when I went indoors and took everything off, the tips of my 2 big toes were white, and they never turned pink again. And so I actually went to the pediatrician, and sure enough, he took a pair of scissors and cut it off. And I never felt it because that tissue had frozen to death. So that's basically how cryoablation works too, is that we stick a needle that has basically a freezer on the tip of it, and we freeze the tissue that surrounds the tip of that needle. And we freeze it in a way that it kills the tissue. One of the big advantages of cryoablation is that, just like frostbite, it doesn't really hurt. So oftentimes we do it without general anesthetic, but just with local anesthetic and sedation. Because, I mean, sticking a big needle in still hurts, so we have to give local anesthetic. But during the process of freezing, that tissue actually does not hurt. The reason why we don't do cryoablation on everyone is that after freezing, we actually have what we call an ice ball. Pretty self-explanatory. It's a ball of ice that's inside you. And over a period of minutes or an hour, that ice ball melts again. And as it melts, things can happen. So there can be cracking of the ice ball so that there can be bleeding. If that ice ball is in the lungs, there can be leakage of air causing collapse of a lung. And in the liver, there is also something something called cryoshock, which no one really understands very well, but where patients can get really sick because the dead parts of the liver are all of a sudden sort of visible to the rest of the body, and the immune system or something basically reacts to it very violently. So we're still trying to determine what parts of the body are most amenable to cryotherapy. The lungs seem to be a good spot, although there is that risk of collapse of the lungs even days or a week afterwards. The kidneys appear to be a really good place. One of the advantages is that cryoablation of the kidney probably results in less leakage of urine than microwave or radiofrequency ablation. So that we're gradually learning sort of the fine points of what advantages one modality has over another.
Okay, last question.
Okay, last question from Ellen. If one does tear, would I be knocked out of a trial? So the short answer is yes. So while you're on a clinical trial, you are not allowed to have anything outside of the trial. Because if you do have any treatment outside the trial, it muddies the picture. Because if there's an advantage if there's a good response, then they can't tell, was the response because you responded to radioembolization, or is it because you responded to the tight test drug of the trial? Likewise, if there's a bad result, if there's a complication and you have bleeding or a blood clot or a fever or something, is it because of the drug or that's on trial, or is it because of the radioembolization? We can't tell. So unfortunately, trials pretty much demand that you go single file, that you can't combine things during the trial.
Okay, Dr. Z, I cannot thank you enough. You have opened a whole new world of possibilities for us, especially when a lot of our oncologists aren't aware of all these different things that might be an option. So what would you advise people to do if they want to look into getting a consultation about these things?
Yes, that's a great question. It's true that even in the oncology world, a lot of oncologists don't know about what interventional radiology has to offer.
Right.
I work very closely at Stanford with a medical oncologist named Kristen Ganju, who I think a lot of you have either met, a lot of you are probably her patient. Some of you may have heard of her through her outreach also, through the LMS Foundation here as well. Basically, I don't treat any sarcoma patient without Dr. Ganju's input. And I think that's part of the advantage of being at a large university, is that we decide by committee what is best, because I don't know what she has to offer either. She has some fancy schmancy drugs that I've never heard of them, and I don't know how well they work. So I cannot recommend to any patient that, yeah, you should avoid Dr. Ganju and come to me, because I don't know what she has to offer. We have tumor boards where all of us assemble into a room, or nowadays all of us assemble into a Zoom call, and we review patients. We say, okay, this patient has this condition. Is chemotherapy best? Is immunotherapy best? Is surgical resection best? Is radioembolization, chemo embolization, ablation best? And we decide as a committee how to go forward. So if you are in a situation where you do not have the benefit of a panel of experts, I would advise you to tell your oncologist, I would like to have a chance to have this multidisciplinary evaluation as a second opinion. And it doesn't necessarily mean that we're going to steal a patient from your oncologist. We don't want to fire your oncologist. We want to be able to offer your oncologist options that she or he doesn't know about in case they are available at Stanford and not in their practice.
Wow, thank you so much, Dr. Z. I can already see people are writing in the chat box how wonderful this is and how much they appreciate it. And we are recording this, so I won't make you do it again.
Well,
but many more people will be able to benefit. Many more people are going to be able to benefit. I'm sorry?
what I hope is that a year or 2 or 5 from now, I'm going to have to do this again because we're going to have new options.
Okay, I'll hold you to that. Well,
Good.
thank you. I think we can all give them a clap if you can see us. Yay!
Thank you.
Thank you so much. I'm going to end the recording. And
Okay.
Thank you
Thanks,
very much.
everyone,
I'm gonna end
and
the
good
meeting.
luck on each of your battles with LMS.